Hi, I'm Kristin. I'm going to be talking about my project, which is exploring the health at every size model for clinical healthcare practice. So first, I want to give you all a little background on health at every size, which is a public health movement that started in the 1960s, and it focuses on weight as a distraction instead of an indicator of well-being. So basically what my project is doing is taking this public health framework and applying it to clinical practice. So the definition of a health at every size clinical practice is practices that affirm a holistic definition of health, that reject the idealizing or pathologizing of specific weights, and acknowledge weight biases while working to end weight discrimination and the creation of weight stigma. So what we already know about weight stigmatization in healthcare. Previous studies demonstrate the existence of weight bias in clinical healthcare providers. Studies have shown that weight stigma is a barrier to healthcare access for patients because if patients are afraid to go to the doctor's office and seek care because they're afraid of experiencing weight stigma there, they're going to receive later discovery of illnesses, which leads to later treatment and more poor health outcomes. Studies have shown, therefore, that weight stigma has a negative physical and mental health impact on patients. What we don't know yet, and what my study looks at, is how can clinical healthcare providers decrease barriers for their patients and make their practice health at every size friendly? And what do clinicians need to implement health at every size? So what my project looked for, I talked to people who agreed with the health at every size framework and were trying to implement it in clinical practice. And I looked for themes and strategies that they had used to implement it. How I looked for it, I completed qualitative case study interviews of primary healthcare providers in the Boston area. So this included nurse practitioners, a physician's assistant, and a medical assistant. So we talked to people on all different levels of care. Example interview questions that I asked were, how do you approach the connection between health and weight? What strategies do you use when you discuss weight with your patients? And if you could allocate resources for making your practice health at every size friendly, where would you focus? So some themes that we found in the answers that people gave to the connection between health and weight. Overwhelmingly, our participants said that they don't value weight as a number, as a health indicator, and they instead try to look at their patients a lot more holistically. Participants also said that they viewed weight as a symptom rather than its own standalone diagnosis. So for example, one participant said, I see weight as a downstream symptom of something else rather than the problem itself, whether it be mental health, hormonal, metabolic, or socioeconomic. Some themes that we found in the answers that people gave to the question about strategies that they use when discussing weight with patients. A lot of times participants said that they really don't bring up weight to their patients. Most of the time it's the patient bringing up weight to them, possibly because they had just been weighed before they came into the doctor's office or because it had been brought up in past doctor visits that they'd had. So in that scenario, a lot of the participants said that they would ask follow-up questions about why the patient is worried about their weight, and that a lot of times it would lead more to being connected to mental health, and they would try to reframe that conversation to emphasize why their weight wasn't relevant to their health. The medical assistant said that when they are getting people's weight, they offer for them not to see it if they don't want to know, and they avoid using words that could be triggering like scale and weight. So some example answers that participants gave to this. One said that they try to reframe the focus on prioritizing recovery when in reference to people who are recovering from substance use disorders, and that changes with the body will just happen, and kind of make sure that they understand how normal the process is. And another patient talking about how they like to answer when patients are bringing up their own weight is they say, I actually wasn't going to bring that up. I don't think that's a priority right now, and go on to explain why it's really not relevant to their health or to the conversation that they came in to talk about that day. So some themes that we found in people's answers to the question about allocation of resources that I thought were really interesting is that there were people questioning if there's value in getting vitals and weights on everyone who comes in. So currently, good practice points at that you should get vitals and weights on everyone who comes in, and if you don't, a good practice flag goes up and says you may have forgotten to do this. But participants said that most of the time they really don't use that information while actually treating the patient. A participant also said that they think it would be interesting to incentivize the quality of patient conversation and patient satisfaction instead of number of patients that they see, so they'd have more time to view their patients more holistically. Overall, the answers to this question really focused on overarching kind of care given rather than little changes that could be done. So one participant said, when we're stressed in reference to a busy ER department, it's viewed as a big burden that this patient's putting upon us when someone comes in and requires a special chair without armrests or extra hands lifting from one bed to another. I'd love to see that change for me and a lot of my coworkers. And this really feeds into the next slide that I want to talk about, which are implications that we pulled out from these answers. So overall, clinicians who agreed with the framework pointed to the difficulty of practically applying it in both training and practice. And a lot of this was related to the structural barriers that are in place that are exacerbating stigma. For example, the limited resources in that last quote, or the good practice flags and things like that. So we believe that increasing resources for taking care of patients of bigger sizes would have benefits to the provider because the provider would be less stressed, and therefore that would help decrease their own stigma and make sure that their rhetoric around their patients when they're talking to their colleagues is more positive. And it would help the patients because they would have access to the resource that they need to receive proper care. So here are my references. And I just want to say thank you everyone for coming, and big thank you to my mentor, Dr. Sophie Godley. You're amazing, and I couldn't have done this without you.
Thank you. That was really interesting, especially learning that this movement has been around since the 60s, which seems like a long time, that its ideas haven't really been implemented. I was particularly interested in your comment that this could actually improve the workplace for healthcare providers in terms of making them less stressed, giving them more support. I'm curious if you also see ways that the Health at Every Size framework could improve all of our healthcare experiences, whether we're seen as being bigger or smaller. I can imagine, for example, people recovering from eating disorders might benefit from changing some of these practices. And I was wondering what your thoughts were about that.
Yeah, that's like a big part of the Health at Every Size framework. And one of the questions that I actually asked the participants during the interviews was, have you seen ways that this weight stigma affects patients of every size and like how it can affect everyone? And they said that a lot of times, like nearly most of the patients that they see will bring up weight. A lot of them will experience that fear of going into the doctor's office and being judged. So it's definitely something that like would benefit, I think, every patient going into the doctor's office if they had that security, knowing that their doctor is going to focus on them holistically rather than on one like random part of their body like weight.
This is very interesting. By the way, I really liked your topic and your presentation. You touched on a few like barriers to the imposition of this health at every size framework in places. Like some people talked about like the number of patients that they have to see, not like versus something else being like incentivized, and like some are education and things like that. So I guess like which barriers do you think are super important to keep in mind when we're trying to get this framework more widespread?
Yeah, I think that's a good question. I think that a lot of people talked about how in trainings it can be really hard there's still like a lot of rhetoric in clinical healthcare training about the pathologizing of weights. And so they said that it can be really hard to like keep these things in mind. And also a lot of times like if the training only focuses on talking about how weight is pathologized, it doesn't really give like alternative ways for the people who are trying to give care that doesn't do that. So I definitely think like incorporating more Health at Every Size framework into trainings would be really useful. I also do think that changing like incentivizing number of patients that they see, like I've talked to a physician who said that they have to schedule patients every 15 minutes, like it's just required. And that doesn't give them like any time to talk to the patients about like so many important things that are going on. So I think switching that and making sure that the physician or the care provider has like the time to actually sit down and listen to their patient about their concerns would definitely make a really big impact. But obviously like this study is very exploratory, and it would be super interesting for like more researchers to go out and test different kinds of interventions to these areas.
Thank you for your wonderful talk. I was just curious if, and through any of your research or conversations, you came across any barriers to implementing the health at every size sort of framework.
Yeah, I think a lot of people pointed towards a lot of it is, like I said, like rhetoric around training, but also like these are structural things like in terms of increasing the budget for increasing resources for taking care of patients of every size, like increasing bariatric stretchers that can fit people, like things like that, are definitely like larger structural barriers that would need to be addressed for like the physician to really be capable of on an individual level implementing that health at every size framework.
Thank you so much.
Thank you.